Good morning, everyone. Welcome to a November edition of High Rounds. I know that we have some guests today, but I think Dr. Wooten will introduce them, or not introduce them, say hello to them. I just want to give a brief introduction for Dr. Wooten, and it's always really fun for me to be able to welcome people who are my friends, colleagues, and just all around wonderful people. So Darcy Wooten is an associate professor in infectious diseases and global public health at UCSD, where she also serves as the ID Fellowship Program Director. Her clinical interests include HIV primary care and general infectious diseases. She is passionate about medical education and works with learners across the spectrum, from preclinical medical students to residents to fellows to early career faculty, including this person. She dabbles in digital education and uses social media to promote ID learning. She enjoys spending time with her wildly colorful 4-year-old Maya, husband Joe, and Aussie Doodle Bourbon. And with that, I will turn it over to you, Darcy, and I'll keep an eye on the chat for you.
Thanks so much. And thanks so much and welcome everybody. Thanks for spending these next 45 minutes or so with me. I'll be presenting some clinical HIV updates, state of the art, pun intended. So we'll be focusing on mostly antiretroviral updates, covering kind of hot abstracts that were presented at ID Week, Glasgow 2022, and then some other conferences. So I don't have any relevant financial disclosures. I received some speaking fees from these educational organizations, and some of the slides that I'll be presenting today were co-created with Clinical Care Options. Before diving in, I just want to welcome our PSTP applicants who are interviewing with our program today. These people are the future of ID and HIV, carving out pathways in as a career as a physician scientist. And so I'm really excited to have them all here. And thank you guys for sitting in and getting to experience what some of our conferences are like, and really happy to and excited to talk with you more during our interviews after this. All right, so here's an outline of the topics that I'll be covering. So HIV and viral hepatitis updates. Then we'll switch gears and talk about some updates with long-acting injectable cabrilpivirine. Talk about some outcomes data in terms of efficacy with antiretroviral therapy for patients who are typically not included in many of our clinical trials, such as those with low CD4 cell count and high viral load. And then finally, we'll go over some investigational agents. As you can see, this is a really wide range of topics that we'll be covering, and most of these are just abstracts that have been presented at various meetings. So we're not going to dive too deeply into these, but just more to give sort of the landscape of what are some of the things that are hot and coming in terms of clinical HIV care, focusing on antiretroviral therapy. So we'll start with some updates on HIV and viral hepatitis, and really the majority of this will be looking at HIV and hepatitis B topics. So the first abstract that I wanted to present was the Alliance study, which was actually presented at the IAS meeting this summer. And I think we probably talked about it a little bit, but it just didn't make as much of a splash as probably I think it might deserve. And so I just wanted to sort of reframe and refocus and bring it back to our attention. This was a randomized controlled trial of people with HIV hepatitis B co-infection who were treatment naive. And they were randomized to either bictegravir FTC TAF or dolutegravir FTC TDF. So obviously the differences between these two arms were which second generation INSTI patients were given, but then also what type of tenofovir containing component they had. And then the primary outcome was a co-primary outcome looking at both HIV virologic suppression as well as hepatitis B suppression, with the current analysis that was presented at IAS at week 48. And the reason why I wanted to present this because I think the results were somewhat surprising and notable. So, oops, I've lost my mouse. There we go. So here are the outcomes at week 48. And I think not surprisingly, rates of virologic suppression in both of these groups, so the blue, purple is the bictegravir FTC TAF group, orange is the dolutegravir FTC TDF group, and rates of HIV virologic suppression were high and equivalent between the two groups. But I think what's notable and what was different was that the TAF containing regimen had higher rates of hepatitis B virologic suppression at week 48, as well as statistically higher rates of ALT normalization. And there were also improvements, although these were low rates overall, of seroconversion with respect to e antigen as well as surface antigen. So I think that this is really interesting and again, not necessarily something that we've seen before, at least in co-infection studies. And I think the take home from this is that when we have patients with HIV hepatitis B co-infection, at least based on this data, I'm much more inclined and conscientious in terms of making sure that patient's on a TAF containing regimen as opposed to a TDF containing regimen. The reality is this doesn't change my practice all that much, since when I am using tenofovir, it tends to be with TAF and much less frequently with TDF just because of the bone and renal toxicity. But that's not the case everywhere. And sometimes there are reasons that we want to use TDF. But I think if you do have patients with HIV hepatitis B co-infection, we really might want to think about using TAF containing regimens. And then I think it will be interesting to see sort of larger or more impactful clinical outcomes as they follow these patients over time. It's of course nice to see these laboratory findings, but also want to take a look at the clinical outcomes as well. So the next study I wanted to highlight is the Beehive study, and this is looking at prevention of hepatitis B among people with HIV. And many people in the audience are probably familiar with this since we are one of the trial sites, clinical trial sites for this study. And this is looking at efficacy of hepatitis B vaccination among people with HIV. I think the importance of this study is very obvious. We know that our people living with HIV have much lower rates of seroconversion following vaccination compared to people without HIV. Depending on which series you look at, rates of seroconversion among people with HIV ranges from 20 to 70%. But in people without HIV, rates are much higher, 96 to 100%. And so I think we're all have been very excited about this new formulation of the hepatitis B, of a hepatitis B vaccine, the Hep B CpG, which contains recombinant hepatitis B surface antigen, along with a CpG adjuvant, which is a toll-like receptor 9 agonist, which in people without HIV, where it's been studied and for which there's a current indication for label indication, shows much higher rates of very high rates of seroconversion and good efficacy. This regimen has also been studied in people who have been more difficult to vaccinate and achieve seroprotection, such as those people with chronic kidney disease. And in this population, the regimen has been studied not as how we're currently using it or how it's currently approved as a 2-dose regimen, but as a 3-dose regimen. But we have limited clinical trial data of this vaccine among people with HIV. And so that's what this study was looking at. This was a prospective open label study. There were 2 different groups. I'll only be presenting the data from group B because that was the only data that was presented at ID Week 2022. Group A is still enrolling, I believe, but that is actually the group that I'm most interested in because that group is looking at how this vaccine, how effective this vaccine is among people with HIV who have previously been vaccinated but did not have a response to vaccination. We don't have that data yet, though. Group B is looking at people with HIV who are vaccine naive, and then they received 3 doses of the vaccine at week 0, 4, and 24. So the inclusion criteria were people had to be on antiretroviral therapy for at least like 2 months or so and have somewhat of an immunologic response. Of course, were had to be surface antibody negative, and then couldn't have any evidence of prior hepatitis B infection or exposure. So were surface antigen negative, core antibody positive, or if they had received the hepatitis B vaccine before, all of those people were excluded. And then their primary outcome was looking at rates of seroprotection at week 28, which per standard is defined as having a surface antibody titer greater than 10. So here are the study results from Group B. Again, these are all vaccine naive individuals. They had a total of 74 patients, which was their estimated power sample size to detect a difference between groups. And 100% of people actually had achieved seroprotection after the 3 doses of vaccine. And 98.5%, so almost everybody, actually seroconverted to a protective response after 2 doses. I think what's really interesting is that 88% of people had super high antibody titers of greater than 1,000. So this is looking to be a really, really good vaccine for people who are vaccine naive. Not everybody converted after the 2 doses, but almost everybody did. And so I think take homes from this and this larger study is that, again, for me, awaiting the results from the non-responder group, that group A is going to be really important because there's obviously specific characteristics about those patients that make them more difficult to achieve seroprotection after vaccine. And the question is, will this more immunogenic vaccine help with those patients? Right now, the vaccine is only approved as a 2-dose vaccine, and I haven't tried giving a 3rd dose yet. I don't know if insurance would cover it. I am using it, even though it doesn't have the label indication, in my people with HIV who are vaccine naive, and I'm doing 2 doses. But then based on this study, what I'm going to do moving forward is check a titer 6 months later, because that's when 98% of people had seroconverted. If they're not, if they haven't seroconverted at that point, then I'm going to go ahead and try and give that 3rd dose of this vaccine series as it's being studied in people with HIV to see if that does the trick. Although I think the vast majority of people will seroconvert after the 2 doses. Unclear what we're supposed to do or what we should do if we do, in fact, end up giving 3 doses and people still don't seroconvert. So I think we'll have to wait for guidance and potentially more data to inform that scenario. And then I think this is a good reminder that we need to really be on top of making sure that our patients do receive hepatitis B vaccination if they're not immune, because we are using more and more 2-drug regimens, which don't contain tenofovir. And so we want to make sure that our patients are protected. And so that's a nice segue and transition to the next abstract that I wanted to present, which is looking at patients who were switched to cabrylpivirine, so off of a regimen that potentially contained tenofovir or other NRTIs that had activity against hepatitis B, and then subsequently developed low-level hepatitis B viremia. So, and I should say that this was a case series that was presented by one of our former fellows who just graduated, Elliot Welford, and done along with our amazing clinical pharmacists at the Owen Clinic, Jeffrey Yin, and Lucas Hill, as well as myself. And so long-acting cabrylpivirine obviously is a very exciting regimen for many of our patients. The guidelines are very clear that if a patient has chronic hepatitis B, we of course should not be using this regimen since this regimen doesn't have activity against hepatitis B. But it's not clear what we should do if patients have positive hepatitis B core antibody, and if there's any issues with that, if we switch patients to cabrylpivirine. And so that's what we tried to look at in this study. So this was a retrospective case series of people with HIV who were switching to long-acting cabrylpivirine, and our inclusion criteria were those who were hepatitis B core antibody positive and surface antigen negative. And then we looked at those patients' pre-switch labs as well as other clinical factors in their medical record. And then we also looked at their post-switch labs, specifically their hepatitis B studies, and looked to see if the switch necessitated any further modification to their antiretroviral therapy because of their hepatitis B study results after switching to this injectable regimen. So at the time of the study, our clinic had switched about 150 patients to injectable therapy. Of these, 25% or so met our inclusion criteria, being core antibody positive and surface antigen negative. And then 3 patients, which I'll describe in more detail in the next slide, developed this low-level hepatitis B viremia after switching. So these show the 3 patients, and I'll go through each one individually to describe their pre-switch characteristics and then sort of what happened after they switched to cabrilpivirine. So patient A at baseline had, of course, core antibody positivity, a surface antibody of 6.5, which we wouldn't define as a quote unquote seroprotective level. They were surface antigen negative, and then their hepatitis B viral load was undetectable. This person had received the hepatitis B vaccination series, the old one that we're using of 3 doses. They had received that twice prior in their medical record. Their HIV was very well controlled. Their CD4 cell count was 677, viral load undetectable on rilpivirine, FTAF, and dolutegravir. At the time of this study, we're still doing the oral lead-in phase for everybody. We're now mostly just going directly to injectable therapy. But at this time, the patient was switched to oral cabrilpivirine, and then after a month, received their first injection of long-acting cabrilpivirine. Labs checked at this time showed that this person's hepatitis B DNA was now detected, but still very, very low, less than 10. And then at their next injection, labs were checked again, and their hepatitis B viral load had gone up to 95, still very low, but higher than before. And their surface antigen remained negative. LFTs were normal as well. So at this time, the decision was made to switch this patient back to bictegravir or switch to BIC-FTAF, and then repeat lab testing showed that their hepatitis B viral load became undetectable once they were back on a TAF-containing regimen. So that was patient A. Patient B had just isolated core antibody positivity prior to switching. Their hepatitis B DNA was undetectable. We didn't have any record that they had received hepatitis B vaccination, at least in our electronic health record. Their HIV also well controlled, CD4 of 351. Viral load was undetectable on dolutegravir, bacavir 3TC. So this patient got switched to oral cab, received their first injection 1 month later, and then labs were checked a week or 2 after that first injection due to just logistical reasons. And at that time, their hepatitis B viral load was 101. So FTAF was added effectively to their injectable therapy. And then at the timing at which they would have received their next injection, the patient was switched to BIC-FTAF. Repeat labs showed after being on a tenofovir-containing regimen, their hepatitis B viral load went back to undetectable. And then finally, patient C, which I think is the most interesting and perhaps the most perplexing of all these patients. This patient had, of course, core antibody positivity, but a surface antibody that what I would think of as pretty high, of 115. Their surface antigen was negative, and they didn't have a pre-switch hepatitis B viral load. This person really struggled with adherence to oral medications and had a little bit of resistance. And so prior to switch, they were on a complex regimen with boosted darunavir, BIC-FTAF. CD4 was good, 432. Viral load was had fluctuated, and at the time prior to switch was 110. So this person got switched. They were very excited about injectable therapy, got switched to the oral lead-in, and then 1 month later, their injection. And at that time, their hepatitis B viral load, again, was very low, less than 10, but detected. And they really didn't want to go back to pills. And so through shared decision-making, the patient continued with the patient's provider, and the patient continued on injectable therapy. And at each time labs were checked, their hepatitis B viral load was, again, very low, but detected, but has seemed to do pretty well staying on injectable therapy. And their surface antigen has remained negative. Their LFTs have remained normal, and they've been asymptomatic from a hepatitis B standpoint. So these are our 3 cases. We specifically called this, hepatitis B low-level viremia following switch versus, hepatitis B reactivation, because I think the clinical significance of this very, very low hepatitis B viral load that we are measuring, it's unclear what this means. Maybe it means absolutely nothing, and we're being overly cautious and don't need to check it. On the other hand, if maybe some of these patients that we switched back to tenofovir, if we hadn't done that, maybe they would have gone on to have a more clinically meaningful reactivation. It's that would have had a clinical impact. So it's really hard to know, obviously very, very small numbers. And we think that it would be really helpful to go back and look at the original studies looking at switching patients to long-acting cabrolpivirine, see if any stored samples are available and to check to see if any patients who were core antibody positive developed the same type of issue and how they did, but we don't have that data right now. So I think take homes from this, again, just a reminder that if you are switching a patient off of a tenofovir containing regimen or to a 2-drug regimen, make sure they don't have hepatitis B infection and check their immunity. And if they're not immune, vaccinate, probably with Hep B CpG. And then this is a very soft recommendation, but for patients who are core antibody positive, maybe until we have additional data, you could consider monitoring them and following their hepatitis B viral load and LFTs and surface antigen before switching and after switching. But again, this isn't really based on a lot of information.
Darcy, there's been a lot of chat. So can I just summarize as the moderator, and then I'll tell you when you need to answer something. So Doug had a few comments about different things, but not surprising that the hepatitis B viral loads were higher in people switched to tenofovir, or were lower in the TAF arm because the tenofovir the tenofovir diphosphate intracellularly, the levels are much higher. So it actually makes sense pharmacologically. This is a reminder from Steve, the Beehive study is still open and enrolling patients living with HIV who hadn't responded to hepatitis B vaccine in the future. Lots of discussion about the grade A recommendation for double dose previous Hep B vaccine versus the Heplisov option, which is a C. And it sounds like that's probably going to be reconsidered because of new data. So stay tuned for that. I think you answered about when you checked hepatitis B viremia. It was about 1 to 2 months after the LA CAB switch, depending on the patient.
Yeah.
Okay. And then Nettie asked why patient A had their hepatitis B DNA checked, and is our protocol to check HPV DNA for all core positive patients?
Yeah, I have to go back and remind myself when that patient had their viral load check. Of course, if they're isolated core antibody positive, that I'm routinely checking to make sure they don't have a cold hepatitis B co-infection and to identify that at baseline. I think the more maybe controversial scenario, which is what we saw in patient C, if you have a really high surface antibody and core antibody positivity, meaning you were infected previously, but developed what we think of as, a good immune response, I don't routinely check for hepatitis B viral loads in those patients. And that's why that patient C didn't have that checked. So I can't remember if patient A had that hepatitis B viral load checked kind of at baseline at entry to care, or if that was just done prior to the switch because we had started identifying some of these low-level viremias, and then we kind of did this routinely on all of our patients.
And then Heplisov is a brainchild of UCSD faculty. That's very exciting. And then your comment about, it remains to be seen if low-level viremia means anything. And a couple of people said, yes, it does. Recent data from the hepatitis meeting shows that it does. Doug, do you want to say anything? I'm sorry that I'm talking for you. I was just trying to be quick.
No, I've just seen a couple of there were several papers in the hepatitis meeting, which I didn't attend, but read reports about that. It's now been documented that low-level HBV viremia has been shown in some cohorts to have clinical consequences.
Was specifically said associated with increased HCC risk. So obviously very important. Thanks for presenting that data. I will turn it back over to you. I think I went through everything.
Thank you. So the last HIV and viral hepatitis abstract that I'm going to present is on Delta. Whenever anyone presents something on hepatitis Delta, I tend to, check my email or start shopping on Amazon, because the idea of if somebody has Delta and I need to treat them with interferon for a year, it just that rarely happens or is not particularly feasible. But I will encourage all of you to pay attention to this abstract in general, because there are a number of drugs that are in development and almost ready for approval for Delta. And so I think it's really important that we kind of bring Delta to the front of the mind, because I think we're going to have some good treatment options soon. So I'm going to go through this fairly quickly. Of course, we all know Delta only occurs with hepatitis B co-infection. It makes disease worse. And what I'll highlight is that we do a really bad job of screening for hepatitis Delta. I put in the blue box on the right the AASLD guidelines for who should be screened, people who have hepatitis B, who should be screened for Delta. But the European guidelines actually say everybody with hep B should be screened for Delta. If you look at how do we do with screening of people with hepatitis B for Delta in the US based on guideline indications, we screen about 2 to 15% of people who are actually indicated for screening. So something that we can all work on and improve, especially because we have some new and exciting drugs in development that we might be able to start offering to our patients. So that's why I wanted to present this. This is just one of many, and I will go through this fairly quickly. But this is bulevirtide, which is a first-in-class entry inhibitor against hepatitis D. And this was a open-label randomized phase 3 study of patients with hepatitis Delta, obviously hepatitis B as well. People with HIV were allowed in this study, but the numbers were just very, very small. And so patients were randomized to either one of 2 doses of bulevirtide, 2 milligrams or 10 milligrams, or the control arm, which was a delayed treatment in which patients got treated later. And the primary endpoint was a composite endpoint at week 48 of hepatitis Delta virologic suppression, as well as ALT normalization. So these are the results from week 24 and week 48, week 48 on the right. And as you can see, both doses of bulevirtide were significantly more effective in achieving that composite outcome compared to the control arm of delayed treatment. Of course, this isn't a slam dunk. 100% of people didn't respond. Just under 50% of people had a response, but that's better than what we have right now. So I think this is still really exciting. Other outcomes that were looked at were fibrosis scores, which patients in the bulevirtide group had improved fibrosis scores. This is a sub-Q daily administered therapy, so a little bit rough in that regard, but it was fairly well tolerated. Injection site reactions were common but mild and didn't lead to discontinuations, and then very, very rarely patients developed marrow suppression, needing to come off of the therapy. So I just wanted to kind of bring that, I know we went through that quickly, but bring that to our attention to really remind ourselves that there are hepatitis Delta treatments coming. And so we need to make sure that we're really doing our due diligence. And I think screen all of our patients, well, especially patients with HIV and hepatitis B co-infection, we should definitely be screening them all for Delta so that we can be ready when these agents become approved. Unfortunately, bulevirtide was just reviewed by the FDA and kind of got killed in committee. So I don't know what the future of it's going to be, if they're going to wait for more data or look at it with, treatment with dual therapy or additional agents, but hopefully will become available soon. It is currently available actually in Europe. So we hope to be able to have it and other options here soon. So that
Darcy, is it okay if I don't know if you and or Doug know why it was killed in committee? Because that's, to me, very interesting,
I just saw the press release from the company that just said they weren't really sure why, but I don't know if it had to do with.
It was actually, sorry, this is Lucas. It was actually manufacturing concerns. So not efficacy, but manufacturing issues.
What a good lead into cabrylpivirine, which was the reason for a 2-year delay for that. Oh, very interesting.
Yeah.
Thanks, Lucas.
Thank you. Anything else, Joe?
No, you're good.
Okay. All right, so we'll move on to updates on long-acting injectable cabrylpivirine. Again, sort of a whirlwind through Darcy's favorite abstracts that I recently reviewed. Okay, so the first study that I wanted to present is the Carousel study. I really love this one. It's an implementation study looking at the rollout of long-acting injectable cabrylpivirine across 5 European centers. So what this study did, there were 18 clinic sites involved, none of which had started using injectable cabrylpivirine. And the clinics were randomized to either an enhanced implementation or kind of a standard implementation arm. The enhanced implementation arm had the following. So they had face-to-face training on how to appropriately administer the injections. They had a monthly continuous quality improvements meeting in which they could troubleshoot things, talk to one another, talk to experts for things that maybe they had questions on. And then they were also provided printed educational resources. In the standard arm, the clinics received those same printed educational resources and then received a virtual training on how to do the injections, and that was pretty much it. So they looked at virologic efficacy between the different arms. And so what you can see here in the middle is that basically virologic suppression was high, regardless if you were in the enhanced implementation or the standard implementation arm, which is really great. These numbers probably would be even higher. I know 87% doesn't look super awesome, but the study was done really at the height of a variety of COVID lockdowns. And so there was a lot of missing data, which accounts for those numbers. There's also no difference in baseline characteristics among the two groups in terms of things like gender, race, ethnicity. And then similarly, rates of adverse effects as well as adherence to the regimen were not different between the groups. Adverse effects were low overall, and adherence was high. So I think this is really exciting to me because at Owen Clinic, we've had so much success at really rolling out, I think, in a very coordinated and effective way, long-acting cabrylpivirine that is totally due to our amazing clinical pharmacists and pharmacy technicians. When I talk to other people at other places, you don't see the same degree of rollout, and a lot of people haven't actually started using it. I think that's because there's both real barriers, but there's also perceived barriers to sort of how much effort this takes to roll out. I think what this study shows us is that really this kind of basic support is pretty good, is just as good as the enhanced support in terms of rolling this out. Of course, with the caveat that this study didn't look at, and it takes place in Europe, right, which has totally different healthcare system and insurance coverage. So it didn't look at other barriers such as insurance coverage, staffing required to sort of make sure that people follow up and don't miss their injections. And if they do, have oral bridge and things like that. But I think hopefully will help to sort of enhance rollout of this approach, because I think so many of our patients have benefited from it. The next two studies I'll present on long-acting cabrylpivirine are post-hoc analyses of pooled data from the original trials, Atlas Flare and Atlas 2M. The first abstract is looking at neuropsychiatric effects of long-acting cabrylpivirine with this pooled data. So this shows, again, in the green, the pooled data from those three studies comparing neuropsychiatric effects between patients who are on injectable therapy compared to patients in the other arm who stayed on their oral therapy. Rates of neuropsychiatric effects were not that high, 9%, but higher than the daily oral therapy. And those were patients who were like continuing their therapy, so unlikely to necessarily develop new side effects on a regimen that they were already on. Things like headache, dizziness were classified as nervous system disorders, and those weren't all that common, 3%, 2%. And then similarly, other sort of the psych disorder side effects, insomnia, abnormal dreams, et cetera. These were low in both of the groups. So overall reassuring, although slightly higher in the cabrylpivirine arm. I think what is really nice is this figure, which shows how these side effects play out over time. And what you can see for all of the different categories of side effects is, number one, they were mild, grade 1 or 2 mostly. And then they also seem to kind of go away after a couple weeks of being on the regimen, and having people sort of adjust to the regimen. So I think, we can expect that some of our patients will get some neuropsychiatric effects on cabrylpivirine. I think we can reassure our patients that these will be mild and that they'll probably go away over time. And then the second abstract that was presented at Glasgow. The second abstract that I wanted to present was a post hoc analysis looking at efficacy and safety of cabrylpivirine by race ethnicity. And this was an abstract presented at ID Week. And I think this is always, when we're looking at outcomes and health disparities by racial groups, I think you have to be sensitive in terms of how you present this data and kind of what you do with it. I think at the same time, we need to constantly be trying to apply an anti-racist pedagogy to our research, our educational endeavors. And so wanting to also look at where these disparities might lie, and so we can know what to do and how to intervene on them. So these are the results and demographic features. Again, when you pull all of these data from these 3 studies and break it down by racial groups and then other demographic factors listed on the left. So 67% of the patients in all of these studies were white, not surprisingly, as we tend to enroll patients from or participants from minoritized groups. 16% were Black, 4% Asian, and then 4% from other races. And then when you look at efficacy, you can see that rates of virologic suppression at week 98 in the intention to treat analysis stratified by racial groups were outstanding, really high rates across all groups, and there was no statistical difference between these groups. So really nice to see that. And then I'm not showing you the data, but just summarizing in the bullets below, adherence to on-time injections was very, very high in these studies, didn't differ by race. Similarly, side effects and injection site reactions were rare and didn't differ by groups, and virologic failure was extremely rare, again, not differing by race. I think this is really nice to see and important to be looking at these things to make sure that we're identifying disparities where they exist. So take homes, I think I've already summarized a bit in terms of the neuropsychiatric symptoms. I think they're mild, they will go away in a couple of weeks if patients do develop them. And then efficacy of this regimen is comparable across different racial groups. And then the last cabrylpivirine update that I wanted.
So, Darcy?
Yes. Hello?
God.
Yeah, I'm sorry to interrupt.
Yeah, you're supposed to raise your hand. No, I'm just kidding. Go ahead.
Can you hear me?
Yes.
Oh, that's okay. I'm driving, so it'd be dangerous to raise my hand. I just wanted to comment quickly that lessons learned from dolutegravir and efavirenz, that with dolutegravir, older people, women, and people of color had more neuropsychiatric adverse events from dolutegravir, and you commented on that, but how frequent it is depends on the composition of the cohort, and some of those effects were not really seen as much until they started looking in clinic communities after the registration trials were over. So that's one point. And then with regard to efavirenz, it was a similar story to what I heard you saying. Oh, these are mild, people adapt to them, they go away. But there are then older data after years of experience with efavirenz showing that efavirenz was associated with cognitive impairment. And more importantly, when people switched off of efavirenz, even when they said they weren't having any neuropsychiatric symptoms, they reported that their symptoms improved. They felt better. So I do think people adapt, but that doesn't mean that there aren't consequential effects on their mental health. And so I'm just bringing them up for, lessons from the past and to raise awareness of those particular issues among the audience.
It's such a great point. Thank you so much for sharing that. I think something we definitely need to keep watching and keeping our eye on, right? Because all of those data that I presented are from randomized controlled trials, which we know is not always totally representative of what happens in real life and in clinical practice. So completely agree with you and appreciate that comment. The next update, and again, I'll speed through.
Sorry to interrupt.
Oh, no, that was great. I love that contribution. Thank you. The next update that I wanted to present and last update on cabrolpivirine is just reaffirmation, I would say, of risk factors that we've identified for virologic failure with this regimen. This was presented by Dr. Hill at our last high round, and this is old data, which has identified baseline rilpivirine resistance mutations, low week 8 rilpivirine troughs, infection with subtype A6A1, and elevated BMI greater than 30 as being risk factors for confirmed virologic failure in patients on cabrolpivirine. And of course, if you have 2 or more of these risk factors, it really increases your risk. This was updated data using an expanded multivariable model. Again, just not changing anything that we know, but reaffirming that these risk factors do in fact increase risk for virologic failure, with baseline rilpivirine resistance mutations having higher risk compared to elevated BMI. And again, having 2 or more of these risk factors significantly increasing the risk. So we know that these risk factors can increase virologic failure with this regimen. I think the one that's the trickiest to deal with is what to do with elevated BMI. For me in my practice, looking at these data, if they don't have any of the other risk factors for virologic failure, a BMI of 30 to 35 for me is not an absolute contraindication to this regimen. And you really need to, I think, individualize it to the patient. Use shared decision-making. If they're not able to take pills, and an injectable regimen is going to be much better for them, even if their BMI is elevated, that might still be the best option for them. It is important to really use, the longer 2-inch needle in people with elevated BMI, and make sure you're using good injection technique, because I think that can mitigate some of this. And then there are studies coming out, and some studies that have already been presented showing that different injection sites and other techniques might help to overcome this issue as well. If I have a patient with a BMI over 35, I would really start to get anxious about using long-acting injectable cabrolpivirine. So that's just me, but I tend to be very risk averse. So more to come on this, I think, in terms of elevated BMI. Just in the interest of time, I'm going to keep moving to our next update, looking at antiretroviral therapy efficacy in patients, again, who are not typically or necessarily largely represented in our clinical trials, those with low CD4 cell counts and high viral loads. This was updated data from week 240, presented on studies 1489 and 1490. This was presented at ID week. Just by way of reminder, these were treatment naive individuals in this randomized controlled trial, where they were randomized to start on either bictegravir FTC TAF or one of 2 dolutegravir containing regimens, and then looked at data efficacy at week 144. The current analysis that I'm going to present is looking at after week 144, when it became open label to bictegravir FTAF, looking at outcomes among different subgroups, those with high viral loads and those with low CD4 cell counts. And so that's what we're looking at here at the graph on the right. And what you can see is that in blue, regardless of whether your viral load was less than 100,000 or greater than 400,000, there were still very, very high rates of virologic suppression among patients on this regimen. In gray, patients with low CD4 cell counts, less than 200, still had outstanding virologic suppression. And then in green, if you had a high viral load and a low CD4 cell count, you were still able to suppress. So I think we've been, of course, using this regimen in patients with low CD4s and high viral loads, but it's nice to see this data that this is effective. There wasn't treatment emergent resistance. The regimen was well tolerated. We did see within the first year in these studies that there was significantly more weight gain in those who had a low CD4 cell count or a high viral load. I don't think this is surprising to anybody because this reflects, and it probably reflects, at least in part, a return to health phenomenon, since these patients had very advanced HIV and had significantly more weight gain. And interestingly, at week 240, there was a similar median weight across all of these different subgroups. So maybe some suggestion that things leveled out over time. So take home from this is that BICF-TAF, which is a regimen that we use very commonly, is going to be quite effective even for patients who have low CD4 cell count and high viral load, and nice to see that data. And then my last update is going to be an update on one investigational agent, not two, lenacapavir. So this was data presented at ID Week, updated from the Capella study, looking at lenacapavir in heavily treatment experienced patients. Remember, the Calibrate study is looking at lenacapavir in treatment naive patients, but this was, there wasn't an update from Calibrate, I don't believe, at ID Week 2022. So this study enrolled patients who had, who were currently failing their regimen. They had to have a viral load of greater than 400 with resistance to 2 or more agents from 3 or 4 of 4 main antiretroviral classes. There were 2 different cohorts. One was a randomized cohort and the other was non-randomized. The patients in the non-randomized cohort were ones who entered the study. They had a repeat viral load, and that repeat viral load showed actually some improvement before any intervention had been done, like a decline of half a log, or had a viral load less than 400. So these people were put into the non-randomized cohort because probably by being in the study, they had better adherence, and that accounted for their improvement in viral load, and they didn't want to skew the results in the randomized portion of the trial. So in the randomized cohort, patients were started on oral lenacapavir or placebo in addition to their failing regimen, and then after 2 weeks, they were switched to an optimized background regimen with subcutaneous lenacapavir given every 6 months. And then we have the week 52 data presented. So this is looking at FDA snapshot in terms of efficacy of the pooled data between both the randomized and the non-randomized cohorts here. And so this is like really good outcomes for a very challenging to treat patient population with a lot of resistance. So 78% of patients had a viral load less than 50, and 82% of patients had a viral load less than 200. There were some virologic failures, which I will talk about in the next slide, and talk about resistance. And then in the image or the figure on the right, when you stratify by the number of fully active agents in the optimized background regimen, I think it's really impressive. Even if you had 0 fully active agents in the optimized background regimen, you still had 75% of those patients have virologic suppression. So kind of cool. We saw CD4 cell counts go up among patients, as you would expect to see. And so a nice option when this hopefully gets approved for patients with a lot of resistance who might not have many other good options. And then this is showing patients who did have virologic failure, and some developed emergent lenacapavir resistance. So overall, again, between both of the cohorts, 22 patients met criteria for resistance testing. Of these, 9 patients developed emergent lenacapavir resistance. And of those 9, 4 patients actually, they continued on lenacapavir and went on to suppress. So 2 of them had a change in their optimized background regimen at that time. 2 of them continued on the same optimized background regimen, but nice to see that those patients went on to suppress, but resistance does and can occur with the M66I mutation being the most common. So take home, lenacapavir sub-Q every 6 plus an optimized background regimen resulted in high rates of virologic suppression in this challenging to treat patient population. So it'll be a nice option once approved for patients with a lot of resistance. Sorry to rush through towards the end, but thank you so much for your attention, and happy to take comments and or questions.
You did it. You stayed within the 8:50 time frame. Let's open it up. Please unmute yourself. There's a clap, but that wasn't it. maybe I went through all the stuff that everyone wanted to talk about. But yes, please, I'll let it be quiet for a minute.
I'll just give a shout out to Tyler, who I believe is on vacation today, but still came and listened to the talk. Thanks for being here, Tyler.
Can I ask a question? I'm sorry, I'm like running out to a meeting, so I couldn't be very well looped in, but this is Nettie, and I was just wondering if you could talk a little bit more about, I couldn't tell if some of the checking of the Hep B viral load was sort of not accidental, but like, you know, done just because somebody was worried. I feel like for some of those patients, giving them Heplisav, or those folks who were core positive, surface antibody low, or surface antibody negative, which I think was your first two patients presented. So I'm just trying to imagine like what might have happened with those folks in the real world, non-research setting, or what some of us might be doing with those folks. And what I think you ended up recommending that we just check viral load for them, but I don't think that's what folks are doing now. And wanted you to talk a little more about that.
I think that recommendation is very, very soft. And I would say is if they're just isolated core antibody positive, I think that's a pretty standard recommendation to check the viral load. But, you know, we started doing this because we saw people reactivating. And so whether to like, there hasn't been a cost-effectiveness analysis to see, does this make sense to do this for everybody who's got a core antibody positive? Is there any way to stratify and kind of see who are at higher risk for developing low-level viremia? So I don't have a great answer for you on that. Lucas, I don't know if you're still on and wanted to go ahead.
Yeah, sure. No, the first one we found, which was patient B in the presentation, happened to be incidental. When a Hep B PCR was checked on some labs, that there really wasn't a specific intention for it, but we found the elevated viral load, and that triggered us to have some concern. And then because of that, we started checking some Hep B viral loads in our core positives, essentially 1 month after stopping tenofovir-based therapy, and identified those 2 additional cases through that process. And we've continued to do this just because we've now had these 3 cases and haven't had any others since. And so it's hard to make of what these mean if we're just picking up occult Hep B cases or not. But
well, like my word of the century is like that I think the word of the year for ID is going to be diagnostic stewardship, which I think is a fantastic word to spread around a lot, using a lot in teaching. So then I'm trying to make sense of this perp as far as diagnostic stewardship. Like, I don't want to start creating a mess, but I will say that a lot of us are kind of checking Hep B viral loads a lot because we get nervous. But then I worry that maybe now we're going to let that nervousness cause us to do a lot more checking. And I don't, you know, it sounds like we just need to have a little bit more data to know what's a reasonable protocol.
But I mean, I think we check hepatitis B viral loads for much less, right? Someone's LFTs go up and someone starts a diagnostic workup. It would seem to me to be quite reasonable in someone who's core positive, where you're removing an agent that was normally directed at suppressing it, to do that check. And I mean, you know, cost effectiveness analysis, I don't know if that needs to be done. I know we're not talking about a huge number of patients. I know we definitely have a lot more patients that are core positive, you know, who are living with HIV. Lucas, do you have Lucas or Darcy or anyone else, any estimate of what those numbers would look like? I can't imagine it's the majority.
Well, I think what, you know, the data Darcy presented, you know, and I can only speak to those that we switched to cabrolpivirine because we've systematically been keeping track of who's core positive, but
right.
It's been about 25%.
Yeah, that was going to be my guess. Ooh, I don't know if that's based in that.
I think,
but
that's
it's not just money.
Yeah,
I think that's
like, you mean if it's actually positive, and then what do you do?
Yeah, and it's an expensive test. It's not like $10,000, but you know, it's not nothing. So
plus, it's not just money that we're talking about, right? I mean, those patients were then told that they had, you know. So when I think about diagnostic stewardship, it's not just about money, right? It's about like just sort of creating a mess, right? Because then it's like, I've now got this data, I have to act on it. Then I tell the patient to do something with it. Then maybe I take them off a medication that they want to be on. So, and I'm not criticizing because we are doing this. I just think it would be nice to have a sense if you said, oh, we haven't had any more reactivations, like what's going to be the best thing to do here? So most of the time when I'm choosing diagnostic stewardship, it's not so much for money, it's for preventing myself from making a mess that I have to clean up, or making the patient change therapy or change what they're doing, or feel worried when it was not necessary, so that's more my concern. But I think we just probably don't know yet. I think most of us will keep sort of checking Hep B DNA until we have a sense of when it's needed.
It seems like, though, the consequences are high from what everyone's talking about, that a low level viremia that ends up potentially being more could be problematic for patients. So it seemed like you would want that data, but yeah, I realize it's early.
And I can see it both ways. And what we need to figure out is like, which patients does it really make sense for, and which patients is it just going to cause worry because they're at lower risk. And so that kind of risk stratification would be helpful. I don't think so, Katie. I don't think they had any other immunosuppression.
If I could just add to the comment about, vaccinating those that have negative surface antibodies. I mean, I know the guidelines recently updated to recommend giving a dose. I think the literature is very weak on even if they develop antibodies or have antibodies, does it prevent reactivation? It seems to be mostly associated with very high hepatitis B antibody levels that may prevent reactivation. So, and then that recommendation from the guidelines to vaccinate in core positive who don't have surface antibodies is only targeting antibody levels. We don't know if that actually prevents reactivation of hepatitis B. So, I get the idea behind it, but I don't know if the data supports that that's going to prevent reactivations or not.
Yeah. I saw what Nettie said, that it's life altering for people. And again, I don't think anyone would say you have to take it away. You could always add a medication, you could add entecavir, you could add something back if you wanted to, if you were concerned about it. But I totally understand, what you're saying. Anyway, this obviously is controversial, and hopefully there'll be more data to come. Thanks, everyone. And Darcy, this, I think, very appreciated, such a comprehensive talk on, maybe some things we haven't talked about in a while. So if there was a question to anyone, will this change your practice on your CME survey? Maybe it will change your practice. So, well, thank you.
Thanks, everybody. Good to see you. Yeah.
Yes, and we're off next week. Enjoy the holiday. If you are off, hopefully it will be restorative and restful for people. Bye-bye.